It's with great pleasure that today I have the opportunity and the chance and the honour to welcome Dr Barry Glassman. So thank you very much for joining me today.
Thank you, Michael.
Excellent. Now, I'm going to start right off the bat and just ask, where and when did you qualify with your dental degree?
So I was graduated from the University of Pittsburgh in Pennsylvania in, you don't really to give you the year. It was 1973.
1973, excellent. I've actually got a little connection with Pittsburgh, believe it or not. My great grandmother's brother emigrated to Pittsburgh with a relative who was Andrew Carnegie.
Oh my God! I thought you were going to say that graduated the same year I did.
No. Well, he may have done. So there we go. Now, I understand, obviously, your clinic and your career has been focused on a number of things: dental sleep medicine, TMJ, chronic pain, head and facial pain, splint therapy. Whereabouts is it you work? Can you tell us a bit about your normal clinical day? What type of things are you doing day to day?
An interesting question, Mike, because you may not know this, but about a year ago, I retired from clinical practice. Still managing to keep very busy with on many topics, such as trying to deal with improving sleep medicine and improving the practice patterns and improving the relationship between medicine and dentistry and medicine and patient care. Both of them present tremendous challenges. And I'm still doing a significant amount of teaching and consulting in the pain and oral facial pain region. So, in 2007, 2008, no, actually a little before then, I dropped general dentistry, and my entire day was focused on patients that were referred either by their physicians, most commonly by their secondary care physicians, and thirdly, most commonly, by their dentists for oral facial pain issues.
Okay. How's that been, dropping the clinical side of things? I guess it must be challenging to get to a point in your career where you are, I mean, presumably you were helping a lot of people who were having a lot of difficulty. Did you find that a difficult personal choice to then decide to drop the clinical side of things?
It was traumatic. It was, no one's ever asked me that. So I thank you for that, because it was, in this particular instance, the most difficult decision of my life, not because it had nothing to do with economics. It was because by no longer practicing, it was my job to try to find a way that my patients who, for whatever reason, whether it was an appropriate emotional tie or a actual required clinical tie, and you and I know when you're dealing with chronic pain, sometimes you struggle personally on the difference. Having said that, yes, it was very, very difficult to write that letter and tell my patients who often continually contact me and ask why.
I'm sure, but I guess part of the balance and being able to regress that is the fact that you're now doing more teaching, presumably, and passing on the knowledge and the skills that you have to other dentists. That's
my hope. So my hope is that what I've learned, and it's really interesting because we have a specialty in oral facial pain, not in terms of American Dental Association, but we've got craniofacial programs and we've got oral facial pain programs. But the programs are very much, they tend to be evidence-based, which is fine, of course, but they seem to forget, and so many seem to forget, that when Sackett wrote about evidence-based medicine, he didn't say or suggest ever that everything we needed to do needed to be quote-unquote evidence-based, and if you did anything that wasn't evidence-based, it was inappropriate. Sackett included appropriate clinical evaluations and experience, in the risk-benefit decision-making when it came to treatment and diagnosis. So there is a large academic side of our field that really tends to handcuff people, because it would be considered inappropriate to use some of the hypnotic things that you're so excellent at in order to help patients. It would be inappropriate to use specific splint therapies because there are no really good studies, when we all understand that we can't do really good studies on splint therapy. And you can't do washout periods. You can't really evaluate them properly, and that there's no way to evaluate. And this gets back to your first question. There's no way to evaluate those kinds of things, when the truth of the matter is that when you're dealing with chronic pain, more important than any of your specific techniques, as long as they're appropriate, is patient management. And you can't. So when you put in a splint, and someone else puts in a splint, and then you want to evaluate the results, the patients weren't the same, because we don't have really definitive diagnoses. We're not good at that. If I said to you, people are still calling it TMJ or TMD, which is absolutely absurd. And then if I said, well, I was treating stylomandibular ligament insertion tendinosis, most of my profession would look at me and say, what are you talking about? So we don't have really good diagnosis. So that's the first major problem. How do you compare a treatment of putting in a splint without an accurate diagnosis to start with? And then a splint is not a splint. If you use in England and Scotland, they use SCIs, or NTIs, or any anterior midpoint stop appliance. It's not the same because you used it. It's following a therapeutic protocol, etc. And so when they try to compare, when they try to do a study, it's lost. And so consequently, if I thought of the number of people that I wouldn't have been able to help if I went only by evidence-based. So many times I'll get a call from some of these patients, some of these docs who had gone to these orofacial pain programs, and they will say to me, to be honest with you, Barry, I can diagnose the hell out of everybody. I just can't help anybody.
Indeed, and one of the things I remember from going on one of your courses previously was this discussion about the terminology in TMD, and I'm sure it was yourself that said that's like going to your doctor and him saying you've got sore knee syndrome or something similar. It doesn't really tell you anything.
Well, exactly. We used to call it TMJ, and then everybody says, well, you can't call it that. That's the name of the joint. You wouldn't say to somebody who's got knee pain, you've got knee. So we changed the J to a D, and now we feel better. Now, it's like going now and saying, getting a diagnosis from your doctor, you've got KD, knee dysfunction. So whether it's patellofemoral syndrome, whether it's arthritic changes, whether it's a fracture, whether it's a medial cruciate or an anterior cruciate tear, all of those things are diagnosed and treated differently. And yet, if I said to most patients, most docs who treat TMJ, are you dealing with a lateral collateral ligament issue? Are you dealing with? Explain to me exactly what the issues are with an anterior disc displacement and its progression, and the possible adaptation of this fibrous connective tissue, this fibrous tissue that this disc is made of, that acts like bone and may not be treated. It isn't the end of the world if it isn't exactly where it was when you were 17. There were lots of things in my body that aren't where they were when I was 17, and I don't want to go into them. But we adapt, and that adaptation and the realistic approach to dealing with joints is often left out by a profession that's looking for that impossible thing to find called perfection.
I think so. I mean, actually, when I've got a master's in hypnosis applied to dentistry, and I chose the topic of bruxism for my dissertation, and I was looking at the research into evidence for hypnosis in bruxism. And what I discovered as I was doing the literature research was part of the reason why we struggle as a profession to manage bruxism is probably because it has a multitude of causes. It isn't a single thing. Yet we don't really ask our patients the pertinent questions. What is their recreational drug habit? How many hours a day are they chewing gum? All these factors that can have a part in the overall issue.
What's really difficult for us is that with all that in mind, we still know that bruxism tends to be centrally mediated. And if I could do anything for dentistry, I would get us to stop thinking linearly and eliminate the word causal. Many things can have associations, and it may not be the thing. Once there's an association, that doesn't mean that, therefore, that particular association, because we happen to be dentists and that association is related to teeth, that's the best way to approach that problem. So we're just not. We want answers. We expect answers, and unfortunately, in our history as dentists, our restorative leaders, our gurus, when there weren't answers, and they had to provide them, just made it up and continued to make things up in order to fill holes and make us feel better. And then our docs go back and find and are looking for that and see it. So that's the true definition of confirmation bias. And now we believe in this mechanism, and we get some people better when we perform that mechanism. The truth is, if we were more honest about that mechanism, we could get more people better.
I think so, and I think also as dentists we need to have a better understanding of these points you're making ourselves, because certainly we see a lot of patients who have often spent a long time with their general practitioner, their doctors. They've had CT scans, all sorts of investigations, where even from my understanding of some of these issues, I can see quite clearly, quite quickly, that all of that was never going to uncover what the issue was.
So we're looking for the checklist or the cookbook, and you said something, Michael, that when I'm sure might have gone over our heads or went past us quickly, and you talked about your research in bruxism. Most of us are clinicians, and even as clinicians, we have a responsibility that wasn't taught to us in dental school. And that was a responsibility to be able to read the science, be able to evaluate a paper, be able to look at the power of a paper, be able to determine how many times it was referenced, be able to evaluate the mechanisms and the methods in that paper, and make some intelligent determinations about the predominance of the evidence and whether that paper was industry supported and etc. Instead, what our profession tends to do is to get hooked into a mechanism and a theory and believe in it, and then become a flag waver for it, and then look to justify it and find literature and find abstracts, and then take pieces of abstracts that support their issues from which they've determined through that confirmation bias. It's a sad state of affairs.
And what do you think? Are there any solutions? Is there any way through this? You're obviously doing your bit by teaching as much as you can and publishing as much as you can. But as a profession, what else could we be doing to engage, I guess, that unity between medicine and dentistry in this particular field?
Nothing. We're doomed. Oh. No,
fair enough.
So I believe that the whole dental school process, education, should change, because the dental school takes really, really intelligent people and almost beats it out of them, and tells you that you're not going to be a tooth carpenter, and creates tooth carpenters. And I don't mean that quite as negatively as it sounds, but then what happens is that we start to, there are so many things that we are taught in dental school that are true, that aren't. And so you've heard me talk a lot about the myths, and there are so many of them. And as an American on July 5th, it's really hard to talk about politics, because you get in a lot of trouble when you talk about politics. And and as soon as I mention any politician in any discussion, people stop hearing what I'm saying because they hear the politician. So bear with me for a second, because it has nothing to do with President Reagan or his policies. And it has nothing to do with the Democrats or the Republican Party, because this could go either way. But what he said was fascinating. What Reagan said at one point, he was talking about Democrats. And he said the problem with Democrats isn't that they're stupid. It's just that they know so much that isn't true. And the problem with dentists isn't that they're stupid. It's just they know so much that isn't true.
Very good. I like that.
I thought you might.
So the practice was in Pittsburgh. Is that where you grew up? Are you from that area originally? Or?
No, I went to school in Pittsburgh. I grew up in the Philadelphia area, and then went to Pittsburgh for college and for dental school. Down to the North Carolina for 2 years as a captain in the United States Army, and then joined my brother in a general practice in Allentown, Pennsylvania.
Excellent. Now, I remember seeing a post that you'd made on Facebook a while ago about your the signage outside your practice. What did you end up doing with that? Is that it's on a museum, presumably somewhere, save for austerity?
That's cute. No, it's actually the building is settles to be sold on Monday, and I left it there. So my real estate agent called me and just today and said, you left your sign there. Should I take it down? And I said, well, my wife's going to be at the closing. I said, well, give it to her, and then she'll put it in the basement, and then my daughter will throw it out when I die.
That sounds like a reasonable plan. What inspired you originally then to look into dentistry when you were younger? Was it something you'd thought of at an early age, or was it kind of later on?
What inspired you?
What inspired me was a neighbour of mine actually was a dentist, and there was a few factors involved, but at the age of 12, he let me put the white coat on, and I walked around the dental school, and all the final year female dental students thought I was really cute, and I thought this could, and as a kid I'd never had any dental treatment. I'd only had a polish, and I thought this is quite an easy job. I could probably polish teeth.
So was there some excuse me, was there some point in your development as a dentist that you looked at your profession and you realized that you really didn't know anything about it when you chose it?
Oh, 100%. I think probably week 2 of the undergraduate course, I realized how little I actually understood of dentistry. Absolutely. So
I think the vast majority of us have no idea what it is to be, because it's exactly right. The only experiences we have are those that we experience as a patient. I never brushed my teeth as a kid. I had lots of decay. I hated going to the dentist. I hated the needle. I hated being drilled upon. So it makes me wonder about my choice. So the reality is that my brother, who was 6 years older than I, was in dental school. And my father died when I was a senior in high school. And there was a severe breakup in the family over the business. And my brother and I decided that wasn't the right thing, the way the world should be, and that we would practice together and function well.
So was your father a dentist as well?
No. My father started out as a cab driver, and then went into business with his father and his brother, and they owned Glassman Glass Company. It was the largest glass company in Philadelphia, auto glass and seat covers and things like that.
Excellent, very good. So over the course of your career, then, what would you say the biggest changes are that you've witnessed or experienced? What's the thing that surprised you the most, and how dentistry has changed since the early 70s?
Wow, it's changed. Obviously, if I look at the young residents that I teach, and I feel for them. I do. I think that, honestly, I think they're brighter than I was. I think they're smarter. I think their educational process is different than ours was, but they seem to come out. Now, don't get me wrong; they don't know anything about our field. It still bothers me that as dentists they don't teach us how people chew, for example. You'd think that would be a nice idea, I don't know about you, but I wouldn't want to go to a podiatrist who didn't know how we walked. I just thought I'd mention that. So we there's lots of things that are missing from our education that concerns me. There's lots of things that are wrong, but that hasn't changed. That was the way it was. What's changed most, the thing that bothers us gray-haired people most, is that that eye on the target of patient care, that personal sense, the responsibility, the acceptance of the responsibility. We are given as dentists an incredible opportunity. I mean, your goal in life is to improve the quality of life of your fellow man. I mean, what an incredible opportunity that is. That most people's goal in life is to sell something that someone else made so that they can get their piece and extract as much money as they can out of somebody else's wallet for that sale, and then pretend as though it's going to help them enjoy their lives. We don't do that. We really have the potential to help people. And rather than express that, terms like closing a case has come into our profession. I know that's important and I understand it's necessary, but I didn't know what an ROI was until 5 years ago. You looked at things and you determined whether or not they would help patients, not whether what its income was going to be, how it was going to result. And admittedly, we could afford it then. We joined, when I got to Allentown, there were study clubs, and we all got together, and we liked each other, and we shared information. That changed when advertising was allowed. That sign that you referred to has my name. It's 1.5 inches high letters. Why is it 1.5 inches high letters? Because that was what was considered ethical at the time. There was no advertising. And when advertising started to come, then it was suddenly who had the bigger ads and who used 3-color page ads in the telephone book. And now it's social media. And I find there's frankly a lot less camaraderie. And that's changed. And that's sad.
It is sad, and I think there seems to be a bit of a resurgence in that. I think in the UK just now there's a recognition of some of the stress factors involved in the profession, and part of that through the regulation, and the profession seems to be uniting a little bit more now, but there's still an awful lot going on that of discourse, and it's a real shame to see it.
Nothing better to create camaraderie than a common enemy, and you certainly have one here. I appreciate that, and that's another thing that I feel badly for. First of all, in America, we live in a very litigious society, so we live in a very regulated society that just drive. There are things you need to do as a dentist that we didn't do. It drives you crazy, and you've got this such an awesome responsibility. It wasn't a responsibility then to take care of patients. Now there's this responsibility to take care of patients while you're weaving your way through the practice patterns or the healthcare distribution system, and you're weaving your way through the regulation system. It's a very, very difficult task. And so there's no wonder why we see more and more kids not wanting to purchase, not wanting to invest, and wanting to join. And then our older guys are saying, okay, well, then I don't have to do dentistry anymore. I can just join, hire these kids and run group practices. And and you and I both know there was something special about that private practice that took care of their patients. And there were private practices, doesn't necessarily mean expensive practices. There were private practices at all price levels to help all kinds of all patients of all socioeconomic levels. That's disappearing.
It's a shame, and I think you had the nail on the head as well about I guess the change in perception of dentistry as a career as well, and that worries me. You know, when early in my career you spoke to most dentists and they would all advocate a career in dentistry. What a wonderful profession, flexible hours, help people. But if you ask dentists now, would they recommend it to a student? Fewer and fewer dentists are saying that they would. I love what I do, and I love exactly what you said. I help anxious patients, and what a wonderful group of patients to work with, for the appreciation for what you're able to deliver. And I still get a buzz and a kick out of coming to work every day, and I worry about the dentists that don't.
Well, there's no reason to worry about it. And those who know me and have heard me talk about the book I'm writing, just so you know, those of you that heard me 5 years ago, it's coming along well. I've written another page. So it's really hard for me to do because it's painful. The book is being written with a clinical psychologist who Dr. Blanchard has met and knows well. His name is Dr. Micah Sadiq. He's brilliant. And the book essentially looks at what happened to us. What did dental school do to us? And it's looking closely at this suggestion that is often understated, but sometimes outwardly stated, that good dentistry is perfection. And there is nothing that hurts us more than the suggestion that when something fails, it's our fault. And irrespective of the conditions, we should be perfect. And we're not. I don't know how to tell you this, but here's the good news. When I did general dentistry, there were some margins that weren't what they should have been. There were some restorations that didn't look like they should have looked. Occasionally, my contacts weren't in the middle third in the posterior. I mean, come on. You saw 15 patients every day, working your tail off. It all doesn't go the way you want. And because we're trained that it should, it beats on us. We don't sit there and say to our assistant, well, that was a pretty good procedure. I would have given myself a B- on that. Or we don't go home and tell Sharon, I saw 15 patients today and 8 of them I did really well. We don't. So who does that constantly, and what does that do to us in the end? And then you add that frustration to the unappreciative patient, where you really tried to do your best and something didn't go well, and they're screaming at you, and they're throwing the dentures back at you, or they're not going to pay their bill, or they're going to go to their lawyer, or the staff doesn't feel as though they're being treated well, or the hygienist is upset because you were 10 minutes late and so yes. Now let's go back to the regulations. Let's go back to the competitiveness. It's a difficult profession, and we were set up well in school to handle the business. We weren't set up well in school to understand our goals, to do our best, but not to expect more from ourselves than is humanly possible. And we were not taught in school that we're not always going to be perfect. So, furthermore, the schools made us vulnerable to all kinds of, in my field, camps. The up and back camp, the down and forward camp, the neuromuscular camp. We become vulnerable to all of these because we weren't given the tools to determine what is based on good science that is being, or art that is being guided by good science.
Absolutely, and I think if you combine everything you say with the advent of social media, of dental awards, all the things that champion that idea of perfectionism, or this is my standard everyday composite kind of idea, the challenge then for the younger dentist is being able to separate that from the reality of, as you say, a busy practice where you're seeing several patients in a short amount of time.
Absolutely, and now take that. So that's the general practice, and we know that the general practice has these basic concepts. The dentist has these basic concepts that he has to have. For example, all of the answers. So when patients ask them questions, why do I brush and clench my teeth? It's because you're nuts, because you're upset, because it's your divorce, whatever. So they expect all these answers. Well, it's hard enough in dentistry. We're looking for perfection in dentistry. You and I both know that you can work really, really hard. You can treatment plan any patient. And when you treatment plan that patient, it starts with the periodontal, it goes to the restorative. And what's the prognosis? Of course, it's excellent. It's excellent. And when the case fails, whose fault is it? It's obvious. It's the labs. Because it's got to be somebody's fault, right? I say this all the time. I say, patients who go to quality dentists and have quality dentistry die with their teeth. Patients who go to quality physicians and have quality medicine die. And when dentistry decided, hey, wait a second, we're not just about teeth and supporting structures. We can have an effect on the temporomandibular joint. We can have an effect on the cervical spine. We can have an effect on the central nervous system through central sensitization. They don't know that. We can have an effect on headache patterns. We can have an effect on craniofacial issues, oral facial pain patterns. Wow. We can go further. I mean, there's dentists that we can have effect on MS and Tourette's and etc. And they go, wow, this is great. So now and when I put an appliance and something happens and they get better, we take that model of total understanding and perfection and take our own model and move it to these new things that we're doing. And so I have to have an answer. So here's the answer. Here's the reason this appliance works. I relaxed all the muscles. Don't start. I put the jaw in the right position. I knew exactly where Guide or Darwin had missed. And I put it in the right position by giving the teeth these indications. Assuming that the teeth are together all the time. I mean, if dentistry just accepted one fact, and that is that the teeth touch 15 to 20 minutes a day, contact total, and that's not MIP. That's some sort of touching somewhere. Somehow, somewhere, MIP would become a little less important to everyone, as it should be.
Well, that message stuck with me because, again, I remember you teaching that on the course I went on a few years ago, and I still remember that. So that's a good thing, I think.
Yeah, it is. That's good. It's nice to know I affected someone.
One of the questions, I guess you've probably already answered this. I was going to ask you, what would you put into a dental room 101? Room 101 being the thing from 1984 where you get rid of it's all the horrible things or exist in this room. There's a TV show in the UK called Room 101 where the contestants get to dispose of something so it doesn't exist in the world anymore, if that makes sense. What would you get rid of from dentistry if it could just disappear?
3 things. Ego, ego, and ego.
Excellent. Okay, that's a good answer. One of the things, again, I remember you talking about at your course was talking about helping dentists unlearn before they learn. You talked there about the myths about occlusion and splints. Other than, obviously the contact being only a very short period per day, what other kind of common myths and misconceptions are there about occlusion, about splint therapy that you think are important messages to get out there to the profession?
So, there are so many things that we are taught that when I say them, people think are somehow controversial. And I've thought hard about this, and I've said, why are these things controversial when they're so well supported and at least should be considered? And what happens is that there are many things that are taught to us that are just part of our being, Mike. They're the ground, the wind beneath our wings. This is exactly what they are. And the fear is if you take them away from me, not only am I going to stop flying, but you're telling me that I have been flying improperly all of these years. I can't possibly accept that. And what I'm saying, that's not my message. What my message is that some of the things that we've been doing, of course, we've been somewhat successful in our mindset and with our mindset. However, if we looked at them more realistically, we could be more successful more predictably, and we might have less of the problem that I think most dentists have that keeps us from moving forward, and that's fear of failure. I don't want to treat TMD. I don't want to treat JMD patients. Those people are all nuts, and a lot of them you can't get any better. So because you can't get a lot of them better, I shouldn't treat anyone. What is that? I shouldn't try to help anyone. It doesn't make any sense. So what's the number one? The number one mindset that we're given is what I call the stipulation of occlusion. If I give any dentist an upper model and a lower model, the first thing they do is put them together and see what happens when the masseter and temporalis contract and stay that way, even though it never happens in function. That's a good bite. What does that even mean? If you look at you go to any course and you see all of the pictures they show, what's the thing they show? The teeth are together. We think of the teeth as together. So they're not. Teeth are at rest. And now that we argue over a joint position. And I want to say, if I could teach anyone anything, I would say add this word to your mindset whenever you talk about anything about occlusion. The word is when. That's a bad joint position. When we look at the joint position. Well, what's the first thing we do if we're going to x-ray a patient's joint position? What do we tell them? Right. Exactly. Put your teeth in a pathological position and let's see. And then I've got these restorative gurus telling me, and I know this will offend some people. I'm sorry. Not really. But that we have to have the occlusions in harmony, so they have to be comfortable with the muscles and the joints. Well, what possible joint do you take to the end of the range of motion, then you have the muscles contracting to get it there, and then you say, is that comfortable? Who does that? We do.
Indeed. The other thing, and I know this is, you probably get asked this an awful lot, and I know it raises itself an awful lot online as well, and it's something I myself encounter being a provider of anterior disclosures, SCI splints from S4S, is the whole concept of the anterior open bite. I recently faced this challenge with a report back I got from somewhere saying the SCI has created an anterior open bite. What is your viewpoint on this? What can you tell us?
Okay, it's a really great point. First of all, it goes back to some basic principles. And the basic principle when you're making any treatment decision is what I call the risk-benefit quotient. You never want the punishment to be worse than the crime. So, use of a SCI or an NTI or an anterior midpoint spot splint or a B splint or any term you want to use, do any of these with the anterior discluder cause a patient to have an anterior open bite? And the answer is it's more likely to have an anterior open bite with use of an anterior discluder than with any other appliance. Having said that, other appliances have caused anterior open bites. What causes the anterior open bite? It's almost never the assumption of posterior supereruption. And if you take these patients that have anterior open bites and you take models and you put them together, and recently Matt at S4S took a case, and they actually had a previous model and they put it on a scan, and then they scanned the new case with the anterior open bite, and posteriors fit perfectly, laid right on top of each other. And that's what we almost always see. And this is the wrong time to go into trabecular changes and why people don't supererupt. But the reality is that they won't supererupt almost all of the time if there's function. The supereruption we see is when there's a tooth and there's no tooth below it and there's therefore no function. Not that the teeth are contacting, but there's no forces with the bolus. It's really important that we not think about the teeth touching when they chew, because they usually don't. So when we did a study with 78,000 applications, so we did now admittedly this is a retrospective questionnaire, and it was myself and Andy Blumenfeld, who was a neurologist, and Jim Boyd and Steve Bender and Don Malaysia, and we did this study, and we gathered all this data. And we found that there was, on 78,000 cases, there was reported from these dentists a 2% untoward effect. And they weren't all anterior open bites. That's any kind of significant untoward effect. So while it's not common, it sure can happen. And how does it happen? Why does it happen? We actually had, and you may know him, we had Mariano Roccabato. So I had Mariano Roccabato came to our office, and we had a group of us that were there, and we had a whole series of patients that had anterior open bites. When you're putting in, we averaged about 3 to 4 appliances a day. Patients get appliances a day. So when you're putting in that many, we had about 10 patients with some degree of anterior open bites. Interestingly enough, in all these cases, the patients didn't care, but we'll get to that in a second. So now we looked at the anterior open bites, and we found that the teeth hadn't changed. But at that point, I was taking radiographs, and we had lateral films on all these patients. And so we retook. He had us take the lateral films again, and in almost every case, there was an improvement in the lordotic curve or a change from kyphosis to lordosis. And he looked at me and he said, "That's it, Barry." And of course, I had no idea what he was talking about. I mean,
did you notice how I was nodding, but I didn't know actually what you were talking about?
So lordosis and kyphosis aren't terms that you're.
I don't think so. No.
Okay, so a lordotic, because you were nodding and I was believing. So a lordotic curve is a normal curve, and a straight neck, or a reverse curve would be a kyphosis. Okay. So as we come forward, we'll lose our lordosis. So with a change in the curvature, he then sat us down and showed us how will we get an altered trajectory. And so the teeth are now coming. And despite what our dentists like to think is that teeth will find their interdigitation, not necessarily. And so they find this altered curvature. And so we've got new muscle engrams bringing the mandible and hitting the posterior teeth first.
They're just coming together differently.
Yeah.
Basically.
At a different angle. Totally. And when does that... So what we teach people is that you should never use an appliance like this in a patient that's asymptomatic or not significantly symptomatic that they wouldn't care. Unless the deep bite is at least 2 millimeters. If that deep bite's at least 2 millimeters, then you'll catch it as it's starting to open, and then you and your patient can make a decision. Do you want to keep it in it or not? Almost without fail, they'll say yes. The only thing it affects is their ability to chew off things. It doesn't affect their ability to masticate, which is fascinating enough. And then dentists then say to me, but it's it's an aesthetic problem. And I say to them, really? So if you go to the shopping mall and you stand outside of Victoria's Secret because your wife's in there shopping, and you're watching and you see 500 people walk by, how many of them are you going to pick out as anterior open bites? Of course you can't. So when you now we go back to something else we had said. When does a patient have an anterior open bite?
When their teeth are together.
When you say close. Exactly right.
Excellent. And presumably, if their symptoms have disappeared, they're probably not going to be that worried about a slight anterior open bite in any case.
A very quick story. A young girl, 17, without being mama drama, because I can't stand that. But this was a severe case of chronic daily migraine with daily vomiting and 3 attempts at suicide. And we treated her with she'd been through everything, and they actually tried medication despite her young age, but it didn't help her. And so she got referred to us, and it was just one of the cases, and you and I both know this doesn't always happen, but she really responded well, and we can give you a theory as to why anterior midpoint stops have an effect on migraine, but it's a theory. It has to do with cerebral blood flow and superior cerebral artery. And Hasegawa did a really nice study that showed that when there's teeth together, that blood flow speeds up the same way it does in REM, the same way it does in migraine. So she does really well, and her migraines are going down. But she keeps opening up, and she keeps opening up to the point where I have to start doing 2 appliances to keep the appliance going and whatnot. And she winds up with about a 9 or 10 millimeter open bite. She's a beautiful girl. I had this case, and I'm showing this case as and I actually show it to dentists because I know when I show it to them, they'll never use an anterior midpoint stop appliance ever, and that their hearts may never stop palpating. That's how upset they get over this. But I think they should know that there's a time and place. I gave that up. I thought maybe that was too dramatic. But anyway, I was showing the case about 8, 9, 10 years later, and I realized that I hadn't seen Amy for 8, 9, 10 years. So I called, when I got back to the office, I said to my staff, get Amy in. If she's in town, I really want to see her. And they told me that, yeah, Amy's around and she's going to come for an appointment. Amy comes for her appointment, and she sits down in a chair, and the first thing she does is she says, Dr. Barry, I need to show you something. And she pulls out her wallet, because it was before iPhones, and shows me a picture of her twins. Now, I know without that plastic, she doesn't have twins. Those kids aren't there. And it's a real emotional moment. I do my best to. So, Amy, that's really great. I said, great, let's check your appliances. And she said, I didn't bring them. I said, why? I said, Amy, come on. She said, bite. She's got 9mm, still a 9mm, whatever it was, an open bite. I said, why didn't you bring them? She said, well, it's been a long time. I was afraid maybe you learned something and you were going to take them away.
Wow.
Yeah. So there's, and yet we have patients who are upset. Mike, the important thing with anything, with you, forget SCI, forget anterior open bite, with anything, it's patient management. If you suggest you tell your patient, listen, we're going to use this appliance. It really has the potential to help you. I know it's going to control your teeth, your grinding and clenching in terms of what the damage that it's done. And it's going to protect your teeth. It's got a really good chance of decreasing the intensity and frequency of whatever symptoms you're having. If you were my wife, and I liked you, this is how I would treat you. If you're my daughter, this is how I treat you. But here's the thing: sometimes we see some minor bite changes, and sometimes they become even more than minor. We need to monitor that, and then you and I make a decision as we go as to whether or not this is something we want to continue. There's not anybody who doesn't hear that and say, oh, so if you put the patient on the team. Now, I haven't sold the appliance. I haven't said this appliance is going to make your migraines go away. I have suggested, and I've done something that we give lip service to. I've put the patient on the team. So it's not my responsibility only, it's ours. It's very important. The number one reason people can't get the massive amount of help that they could get from anterior midpoint stop appliances like an SCI is fear of failure.
That's true.
We don't put in a crown and say, now I'm going to give you this crown. Would you like me to make this crown for you? There's a 70% chance you're going to be able to chew with it. Okay. Who does that? All right. And yet I put in a sleep appliance, and there's a X percentage chance it's going to make their sleep apnea worse. Fact. I'm going to give them an SCI. Their chief complains of migraine. So what are the chances of this helping? I said, I don't know. I'm not. Well, what are the numbers? I said, I'm not. I'll be honest with you. I'm not giving you numbers. I'm not. What are you avoiding? I said, I'm not avoiding anything. The fact of the matter is that you're a unique patient, and I wouldn't be giving this to you if I didn't think it had the chance to help you that was worth a try.
Would you ever refer to it as a diagnostic appliance? It's something we've sometimes referred it to with regards to that expectation of the patient that we're going to deliver something that we believe has a good chance of helping, but whatever happens, we get information. So if you find there is no benefit, then that's still information that we can use.
That's great. You're smarter than me.
Use that if you like.
Thanks. Is it? Do I have to put the gal name?
Well, I stole it from somebody else.
Don't we all? And that's true. I mean, there's what's really fascinating is there's unlike some of my cohorts, my fellow people in the field, I don't have an appliance with my name on it, and I don't have. I've created nothing. I really have. I've stolen everything. We just wrote a paper. Michael, you'll be happy to hear this. We just wrote a paper that was accepted by Headache, which is a really it's very, very exciting. It was written by the neurologist, the chief of neurology of the Headache Center that I taught the sphenopalatine ganglion injection to, and then he's been using it on his migraine patients. And we just wrote the paper and just got accepted by Headache on the use of the sphenopalatine ganglion injection in migraine and cluster. So we're very, very excited about that. He would love, because he refers his patients back to us. He doesn't like to do the injections if they don't have appliances. So we had to do these without them because it would have complicated the study. But then after we got the study results, many of them came back for appliances.
Excellent, good. I know you're obviously involved with Dentaltown in the States. Is that correct? Do you have a role with Dentaltown?
No.
I thought you did. You just articles and contributions with it.
As asked. So I don't. So I do some Howard Goldstein's what he's done with that CE program is fabulous. And Howard happens to live in Bethlehem, which is a town 15 minutes from me. And I've known him for years. And so he's asked me to do, I've done 3 or 4 courses that are online for Dental Town. But I don't have any official role. They censor and change all of my posts the same way they do everyone else's.
Well, that's good. At least you're not singled out.
No, I'm not.
Now, I know from looking at your Facebook posts, you've got a love of the theatre. What are you planning to see when you're here in London? What's on the list?
That's really fun. So I've got to throw out a thank you to S4S and Neil and Matt. This is our 6th year running, and it's really, London is my wife's favorite town. If she could move here, she would. We are theater fanatics, and there's something very pure and wonderful about the theater here. So tonight I fly back from tomorrow night after the course. I fly back to London, and Sharon will have flown in the morning, and then I will spend the next 5 days trying to keep up with my wife as she goes from theater to theater, and I don't have any idea what we're seeing until it starts, and sometimes I don't know what we saw when it's over. But I know that she's trying to get in to see Harry Potter. I had done the show. I played Roy Cohn in Angels in America, parts 1 and 2 in the States, and so we were here, and I got to see Nathan Lane do it last year at National Theater. He was okay, but whatever.
That was going to be one of my questions, asking about the. You were also in. It was Tuesdays with Maury, you said there. So, what I guess what got you involved in the acting, and what is it you like about that?
That's fascinating. So, Sharon was involved in drama when I met her, and that was one of the ways that I could get to spend more time with her when we were dating. And she was teaching, and she was teaching, and then when we went to North Carolina, I was a captain in the dental corps, and they had a theater there, and they had a wonderful theater program with an incredible director, and I think I just had some innate skill. I'm not trained, but I did very well and really loved it. And then when we came to Allentown, Sharon became, within 2 years, became president of Civic Theater and stayed president for 38 years. And we have worked very, very hard at that particular theater, but at other theaters. And we have a full-time director there. So it's a full-time artistic director and using relatively amateur talent. But the talent in our town is simply mind-blowing. We did a Rent that was incredible. I mean, the shows that they've done, it's just amazing, and I've gotten some really good opportunities. I've done things like the lead in One Flew Over the Cuckoo's Nest, and a whole series of really excellent opportunities that I've had. And Tuesdays with Maury is a wonderful 2-person show about Maury Schwartz. Did you read the book?
I haven't, no.
Okay, so Maury Schwartz was dying of ALS. And decides he was a student. As a teacher, he had a student that got very involved in sports journalism when he left, and forgot his teacher. And then Maury Schwartz was actually on Ted Koppel on Nightline, and was interviewed. And the students saw him, and they came back and wound up coming back to see Maury every Tuesday as he is deteriorating with his ALS, but looking at life positively and giving his student a lesson in how to live and how to die. It's a beautiful piece.
Well, it sounds it. And I guess, I mean, it didn't really surprise me when I learned that you were involved in acting. Seeing you present, because being able to be an effective presenter is you're kind of on stage when you're engaging a room of dentists or doctors. And I guess part of that is being yourself, and part of that is an ability to understand your audience as well. And one of the things I loved about going on your training course was the energy, the passion, and just that natural ability to engage with the audience. You know, obviously I've got a background in hypnosis behavior, and you know, when I'm confronted with somebody who's very good at what they do, you can never mimic or replicate anybody, but you can pick out characteristics that you think this works. So I thoroughly enjoyed your style of delivery as well as the content.
That's interesting. You know, I have a message there. So yes, the theater experience was helpful. The ability to project, the ability to change volumes, and but it's not teaching. And that came from another source. When I was originally asked to teach by bioresearch, I came home and said to Sharon, I said, well, you know, who is a teacher? Guess what, Sharon? I'm going to teach too. And she said, well, who said you know how to teach? I said, well, you know, I've been studying. I know my stuff. I think I can help people. She said, you're going to suck. You don't know anything about teaching. I said, well, maybe you can help me. She said, no, I'm not going to sit there and watch you fail. So I taught for a couple of years. And she refused to come. And then we went to a Las Vegas course, and long story short, she stops in and sees me teaching for a little bit and then goes back out. And I saw her, and I'm a nervous wreck. So we're at dinner that night, and when we're at dinner, I'm waiting, and she's not saying anything. And finally, at the dessert, I said, well, you were there! And she said the following: you know, we're married. Which she didn't have to tell me. Well, you know, we're married. And I've watched you over these last 10 years grow and recreate yourself. But I had no idea how much material you understood and clearly mastered. And if your goal was to let everybody in the room know that, you succeeded. If your goal was to teach them, you sucked. And what it made me realize is that if it weren't for Sharon, I would have become one of those teachers who I've now learned to really abhor and feel badly for, that they don't understand, that they don't need to make up answers when asked questions, that they don't need to know, they don't need to know more than they know, they don't need to pretend that they know more, and that because they've been asked to speak doesn't make them any more authoritative than anyone sitting in that room. And that is a sharing and learning experience. And then she taught me how to watch, when you can, each and every person, and know when they're with you, when they're not, which is a visual learner, which is the non-visual learner, etc. So there was so much about teaching, and there's no way I would have become what I think is a potentially effective teacher and altered as hopefully as many lives as I have been able to. Without, I would have become just like what I see, and I don't think I'm any. You know, I just think I was fortunate enough to have Sharon guide me there.
Well, I mean, certainly, as I say, it's extremely effective. And as a teacher myself, and you know, hypnosis and anxiety management, I don't really get a greater thrill than hearing back from other dentists that they've used things that I've passed on to them with their own patients with successful results. Occasionally I get dentists saying to me, you know, Mike, you know, you should hold some of this stuff back. You know, you shouldn't tell everybody everything. And you may get the same feedback yourself sometimes, but you share everything in order that as many people can get helped as possible. And certainly things I have learned from you, I've used successfully with my patients, and for that I'm very grateful. So thank you very much for that.
So it's one of the things, you know, I teach, one of the things I teach, Mike, is that dentistry tends to, all of us in life, tend to, especially in a dental practice, and in our lives, we live hills and valleys. We look for, try to create positives to balance the negatives. And the higher the positives and the lower the negatives, the rockier our road is, no matter what. And then we wind up trying to change the negative, the belief of the negatives, so that they're not quite so negative, and we've become agendaed. And what I try to teach is to level. So many people say it must be wonderful for you, when patients come, they hug you, and doctors really say how much you've helped them. And I said, no, that's yes, I'd rather help them than hurt them. And yeah, that is wonderful. And it is sometimes a little overwhelming to me when I think, at this point in my career, the numbers of people in the world that have been helped by the conservative approach that I teach in orofacial pain through the docs that have taken my courses. But I try to keep that in perspective. When a patient comes to me and wants to hug me and say, look what you did for me, my answer is, wait a second. You know this appliance that we put in together every night? Who takes this big hunking piece of plastic and puts it in their mouth? And you do. So this is wonderful, but this is yours as much as mine. Now here's the thing. Tomorrow night, you might have a headache. It's okay. So if you accept all that hugging, it's almost as though you accept the fact that you've won. And now, if it goes awry, the patient comes in and says, "You had it right before. Put my bite where it's supposed to be." It's problematic.
It is. Well, I mean, this has been an absolute pleasure to chat with you, and I could keep going, but we should let you have a bit of R&R. Are you planning to see a bit of Glasgow while you're here? Do you know any plans to do anything?
I don't know. I have to ask Neil. Are we planning to see? But probably not. We're probably planning to see the hotel room and a dinner, and then get Glassman to bed because he's got to get up early tomorrow to teach. So
it'll be an absolutely packed day. I'm absolutely sure of it tomorrow. So, well, listen, thank you very, very much indeed, and I wish you safe onward travels. Enjoy your time in London, and I hope Sharon has a great time as well. And I feel excited for the dentists that have taken your course this time. You're going to love it, and when you come back, make sure you get on this man's course. It is fabulous. Thank you very much.
Thank Michael. I've been interviewed a lot. It was really a very well thought out, and your thought processes are very much appreciated. It was a great interview.